This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with Neurology Podcast and Thomas Jefferson University. I'm on the line with Michiko Bruno from Queens Medical Center and John A. Burns School of Medicine in Honolulu, Hawaii, and Larry Golbe from Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. Michiko and Larry are part of the authorship team of a paper that was published in Neurology Clinical Practice titled A General Neurologist Practical Diagnostic Algorithm for Atypical Parkinsonian Disorders that was published online on August 16th of this year and will be in the December 10 print issue of Neurology Clinical Practice. In this paper, members of the Diagnosis and Treatment Working Group from the Cure PSP organization used a literature review and expert consensus to develop a resource for non-movement disorder specialist neurologists to use in their practice to help recognize, diagnose, and establish treatment for patients with atypical Parkinsonian disorders. We invited Michiko and Larry onto the podcast to go through some of these clinical approaches that hopefully will allow you all to keep these atypical disorders in mind as you're seeing Parkinsonian patients going forward. Michiko and Larry, welcome to the podcast.
Thank you.
Thanks for having us.
Michiko, I want to start with you, and you and the authorship team introduced this paper with some data from a survey that was led by Cure PSP, which found that patients and their care partners revealed that there was a lack of familiarity with atypical Parkinsonian disorders, and that was an identified barrier to care. Why is it important that we overcome those barriers?
It's very challenging, even for experienced specialists, especially early in the course, because there is no biomarkers in many of them. Hopefully this will change and more to come. And a lot of these diseases overlap in their presentation. The old adage of patients don't read the textbooks. And the diagnostic criteria says exclude other disease without really telling us how to do so. The symptoms can span into different categories like cognition, autonomic, eye movements, transcending the classic disease pattern that we're used to in our training. And speaking of that training, I think many neurologists have had little training on the four main atypicals, the PSP, the MSA, the CBD, and DLB, because there have been no specific treatment. I think the neurologists are super busy, and once they make the initial diagnosis of Parkinson's, they may not have time to reevaluate the situation, or even they suspect something is a little bit off, they might be a little bit afraid to bring it up in a more devastating disease category. But going back to why it is so important, because patient and family often know something is a little bit off, and they repeatedly tell us that they truly appreciated getting the correct diagnosis, understanding what's going on, having clarity. They can focus on safety and quality of life issue, avoid unnecessary tests, and there may be clinical trials in the future.
I think you're right. I think it's challenging. And as you said, there aren't great biomarkers that help us distinguish and discriminate between these disorders, and the time limits on practice and maybe some lack of confidence in recognizing these disorders could give some hesitation in changing the diagnosis away from a more typical Parkinson's disease. And so given that, Larry, and turning to you, this paper tries to really keep things practical by giving readers tables and figures to try and help dial in and hone their diagnostic considerations. And your paper notes that one of the most common reasons that clinicians should suspect an atypical Parkinsonian disorder in someone who previously was diagnosed with Parkinson's disease is the observation of either a modest or a short-lived response to levodopa. Can you help us drill down a little bit and define what that means? What types of levodopa responses are modest or not even that strong, or which ones are insufficient? When we're using levodopa, when should red flags go up that maybe this isn't a appropriate levodopa response for a Parkinsonian patient?
As kind of a preface to my answer, levodopa at best would only help the Parkinsonian features. In other words, the rigidity and the bradykinesia and maybe the rest tremor, if there is any. Of course, maybe the falling, the vocal volume, and the swallowing might respond secondarily to the extent that the Parkinsonian features are contributing to those disabilities. So don't set up unrealistic expectations with the patient for the levodopa. Now, in order to know whether the levodopa is having a benefit, you have to have a baseline. I mean, just jotting down Parkinsonism is mild is not going to do it. You have to have some kind of quantitative measure. And a great one to use is the UPDRS, the MDS UPDRS Part 3, which is the motor section, easy to use. And so once you diagnose or suspect an atypical Parkinsonism, then you can use the disease-specific scale for that disease. And the major degenerative atypicals do have their own scales. Now, a typical definition of failure to respond to levodopa, I have to say typical because the literature has all kinds of definitions. And our working group just put our heads together and settled on one, and that is a less than 25% improvement in the UPDRS motor score after about a month or two on levodopa, after reaching at least 1,000 milligrams per day, with carbidopa, of course. And we recommend that if at 1,000 milligrams, if there's no important side effects but insufficient efficacy, then you can crank it up to 1,200 milligrams. As for how much time to allow, in other words, suppose you see a good response, but then it starts to wear off. I mean, how do you decide whether it's wearing off too soon? Well, I think most neurologists who treat any kind of Parkinsonism have a good idea of how that works with regular Parkinson's disease. They know that if you start at the average time of about a year after onset for levodopa, that you only have to use maybe 200 milligrams, something like that. And you have to increase that a little bit at a time. And you don't start to see real fall off until an average of 5 years after onset. With the atypicals that respond to levodopa, it'll usually be a much faster fall off than 5 years. I mean, we're talking 6 months to a year.
What I'm hearing there is, one, make sure that if we are going to assess a response to levodopa, we want to be focusing really on those cardinal motor features of Parkinsonism rather than non-motor or the less motor features of Parkinsonism, and quantitate what we're seeing and use a rating scale that gives you a numerical value like an MDS UPDRS Part 3. And keep an eye out for those that are having a less than 25% improvement once you get that dose up to 1,000 milligrams total a day of levodopa. I think those are all helpful points. And so let's follow up on that. And let's say our listeners have done that and they have a concern that a patient's levodopa response is inadequate by those criteria you just described. What are some other key general clinical observations that should make those neurologists or healthcare providers consider a diagnosis other than Parkinson's disease in these Parkinsonian patients?
For the general features of the more common degenerative atypicals, the one figure in our paper, which is really a flow diagram showing how to use all the tables in the paper, that lists 22 features that should arouse suspicion that a patient with motor Parkinsonism actually has an atypical as opposed to idiopathic PD. And we divide them into cognitive behavioral, ocular, motor, autonomic, and general. You're asking about the general, and those are the short or inadequate levodopa response, which we've just discussed, a more rapid progression relative to what's typical for Parkinson's disease in a patient of that age. Now, let me just add something. If we're talking about the atypicals that don't respond much to levodopa, I mean, something like PSP, CBD, MSA, they all have a survival of like 7 to 8 years on average. Now, the survival of Parkinson's disease before the levodopa era was only about 9 years, not that much better. So the underlying disease in the atypicals doesn't progress all that much faster than PD. It's just the poor levodopa response that's the real tip-off. Another big tip-off is that for a lot of the degenerative atypicals, balance and falling issues are important early, sometimes the first feature. So pay attention to that and don't let the patient or the family mislead you by saying, oh, they just tripped over the threshold at the doorway. You have to really drill down and be very prosecutorial in eliciting that symptom. Then there are non-neurological signs of all the rare atypicals. I'll just mention a few that tip off to treatable conditions. For example, Wilson's disease, extremely treatable. So you look for signs of liver disease. Kaiser-Fleischer rings. These are things you have to look for deliberately. They're often not going to hit you over the head. Niemann-Pick type C, treatable, but you have to palpate the abdomen for organomegaly. general medical things like hypothyroidism, neurosyphilis, HIV affecting the brain. These all have their own signs that physicians are familiar with, and they're all quite treatable.
Thanks, Larry. And I agree that the question is a little bit challenging, like you said, with general observations. And it's important to note that the devil is in the details. And this paper lists lots of disorders that can cause Parkinsonism that would have a poor response to levodopa. And a lot of the clinical features that are going to clue us into those disorders are going to be maybe more specific than general, but thinking about rate of progression, although not that much different than regular Parkinson's disease. I think those are all very good points. And Michiko, I want to turn to you, and Larry referenced that beyond the general features, you and the authorship team did create these broader categories, the cognitive and behavioral category, the ocular or ocular motor category, other motor features, autonomic features, to help us sort out clinical features that we should be watching out for. And so can you describe those categories a little bit more and point out some key clinical observations within those buckets, so to speak, that, again, might be indicative of an atypical disorder instead of Parkinson's disease?
We don't expect everybody to remember every single disease or every single tip. So we just wanted to create, first of all, a framework that the neurologist can refer to. And so the broader category are to expand our mental framework and ask more broader question in general, because often clues are there, but it's a little bit all over the place. So in thinking of like cognitive behavior, if you have impulsive, disinhibited echolalia and a frontal syndrome. For example, I do the clap test where you ask the patient to clap, mimic me, like clap 3 times, but then the patient keeps clapping. That could indicate a frontal syndrome with progressive supranuclear palsy. Or one tip, maybe one clinical tip, if we could improve the ocular examination, it doesn't take too much, but if you can look for square wave jerks, or slowing down of downward saccades or square wave jerks are common early in progressive supranuclear palsy. Talking about motor, they may have a little more atypical, usually symmetric and motor multi-system atrophy or PSP, and more axial symptoms. Parkinson's disease can have autonomic symptoms as well, so it's a little bit difficult to distinguish sometimes, but urinary retention is rare in Parkinson and more common multiple system atrophy. And if you had like cortical signs in addition with very asymmetric apraxia, myoclonic jerk, dystonia, that could potentially indicate cortical basal degeneration.
This paper does develop a really great clinical framework, as you said. Larry, I'm hoping you can teach us a little bit about imaging. And while this paper does touch on some of the functional imaging modalities that are available, like dopamine transporter imaging or FDG PET imaging, you and the authors mentioned in the paper that some of those functional imaging biomarkers might be better executed and interpreted by subspecialists with additional expertise in movement disorders. And so given that, the paper does devote a lot of helpful space to talking about MR imaging. And so when it comes to getting a brain MRI, on which patients should we be obtaining an MRI of the brain? And if we do, what are some key radiological features for us to be looking for on those images in the context of atypical Parkinsonian disorders?
I think the reason that the more arcane type of imaging should be referred to a subspecialist to order and interpret are that they're just not very common. So it won't interfere much with our overall goal in this paper of empowering general neurologists to take care of most of the patients with atypicals. So which patients with atypicals need an MRI? All of them. If they can't have an MRI for some reason, they should at least have a CAT scan. And what do you look for specifically? Of course, the neurologist should look at the images themselves, not rely on radiologists. Even neuroradiologists are not very well attuned to neurodegenerative diseases. It's a shame. They're more attuned to surgical type things, vascular, neoplastic. So look at the images yourself. There are some obvious items to list: the enlarged ventricles in normal pressure hydrocephalus, multiple small infarctions. Of course, these two things are treatable, and the multiple small infarctions are treatable in the sense that if you can identify a cause for the infarctions, like high blood pressure or atherosclerosis, you can take steps to mitigate that, to reduce the chance of further infarctions. Deep midline mass can cause Parkinsonism. I saw a patient about 20 years ago now, a woman in college who was having gradual progressive Parkinsonism. Looked pretty classic, but her MRI showed a benign-looking tumor in her midbrain. We didn't biopsy it because various reasons, and I gave her levodopa, responded beautifully, and she's still responding beautifully. She's progressing a little bit, but without the imaging, that wouldn't have been possible. So beyond those basics, there are some other MRI signs of treatable atypicals. For example, the autoimmune encephalitides, paraneoplastic encephalitides may have some inflammatory changes. The hypoparathyroidism could have basal ganglia calcifications. Whipple's disease can have hypothalamic inflammatory lesions. Mitochondrial diseases can have non-vascular distribution of strokes. And there's a long list, which you can see in our paper. And then there are MRI signs of things without specific treatment, but still with potential for referral to trials, like PSP, which has the famous hummingbird sign, which is just a disproportionate atrophy of the midbrain, as seen in the mid-sagittal cut. MSA has the famous hot cross bun sign, which is gliosis in the pons. CBS, we call it CBS because you don't know yet what the pathology is, has asymmetric atrophy in the cerebrum generally. Other things like juvenile Huntington's could have the caudate atrophy, and Creutzfeldt-Jakob disease, not treatable, but you want to make sure that there's no transmission. And so you should be able to recognize the diffusion changes on the MRI in that disease.
And Michiko, I think when we think about atypical Parkinsonism, Larry has outlined a lot of things that are not primarily neurodegenerative, as well as the more primarily neurodegenerative diseases like PSP and dementia with Lewy body or MSA. But is there more that you would say to comment on some of these potentially treatable conditions, right? We talked about normal pressure hydrocephalus is potentially treatable if we can work with our neurosurgery colleagues to divert CSF, or the immune-mediated disorders or other structural things. And so when it comes to potentially treatable disorders, what other advice do you have for practicing neurologists to help them recognize and diagnose potentially treatable causes of Parkinsonism?
There is a lot of paper about each specific disorder, but we really wanted to mimic the real life experience of us, the providers, when patients present to us without the diagnosis. So we wanted to, again, elucidate the approach. So we have the table 4, and the column lists the bigger, broader categories. For example, having family history, even more rapidly progressive history than the neurodegenerative condition, like within month changes, or non-neurological systemic symptoms, for example, of course, fever, skin changes, signs of liver, renal disease, or even within neurological patients having non-movement, such as neuropsychiatric, neuromuscular ataxia predominant presentation. So again, going back to really getting a good history, good examination. We already touched on Wilson disease. Normal pressure hydrocephalus patients may have had a history of intracranial hemorrhage prior, or even if the genetic condition is not currently treatable, family may benefit from genetic counseling. There may be future trials.
Go back to your history, go back to your exam, look for systemic signs, look for some of these more specific clinical features, and look at the paper and the figures you've provided. Look at the sort of clinical buckets that you've organized these clinical features into, and then when appropriate, either conduct more testing or refer for subspecialty opinion when you feel it's appropriate. I've been speaking with Michiko Bruno and Larry Golbe about their paper that was published online in Neurology Clinical Practice titled A General Neurologist Practical Diagnostic Algorithm for Atypical Parkinsonian Disorders. Please check out the article in Neurology Clinical Practice, which is online now and will be in the December 10 print issue. And thanks, Michiko and Larry, for joining us on the podcast.
Thank you, Jeff.
Thank you so much, Jeff.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.